Thank you for joining us tonight. We're really excited to finally host our Children and Teens with Migraine webinar. This was originally scheduled for earlier in the fall. Unfortunately, we had to delay it. So it's with great excitement that's finally happening tonight. Our keynote speaker, I'm proud to say, is Dr. Marissa Lagman. And before we begin, we just want to say that we are proudly supported by the following sponsors. Without their support and contributions, events such as these would not be possible for us. And today, the agenda is I will do a quick Migraine Canada introduction, followed by an introduction of Dr. Marissa Lagman. Dr. Lagman will then take over with her presentation, and the end portion of this evening will be questions and answers. So Migraine Canada, who we are. We are a federally registered charity supporting all Canadians living with migraine and headache disorders. Our mission is to improve the lives of Canadians with migraine and other headache disorders through advocacy, awareness, education, research, and support, our 5 pillars. We do want to make note that developing resources for children and families is very important to us. So with that in mind, when we do email the link to this webinar recording, we will be including a short questionnaire that we ask you to complete. And this is to help us better understand your needs, what resources you are looking for to best support your child or children who have migraine. You can also check out the pediatrics page on the Migraine Canada website for other resources that we have finalized. And this is December. This is our last webinar of 2023, but please stay tuned. In the coming weeks, we will be releasing our webinar schedule for the first quarter of 2024. Before we begin, we always present our disclaimer. This webinar provides information and not medical advice. Note that the information presented and discussed might not apply to your own medical situation or that of your child's. And we ask that you always discuss medical treatments with your healthcare provider who knows your medical history or your child's medical history. Dr. Marissa Lagman is a fellow of the American Headache Society and UCNS diplomat in headache medicine. She is the director of the headache program at the Hospital for Sick Children, an associate professor in pediatrics neurology, the director of the Comprehensive Pediatric Headache Center and Young Adult Headache Transition Clinic, as well as the director of the education program of pediatric neurology at the Children's Hospital in the London Health Sciences Center at Western University. At the University of Toronto, Dr. Lagman conducts research projects and is the co-chair of the Transition of Care Committee in the Department of Neurology. Dr. Lagman's areas of interest include the pediatric CGRP trials, migraine variants, peripheral nerve blocks, migraine in women, menstrual migraine, management of pediatric post-traumatic headache, intractable pediatric migraine, acute treatment of migraine in children and adults, pediatric migraine variants, and others. And with that, I'm going to stop sharing my screen so Dr. Lagman can take over with her presentation.
Thank you so much for the nice introduction. And I know I'm closing the 2023 webinar series. I hope it's not too late. I hope I will close it with a bang. Please feel free to post your questions. I'll try my best to answer them as much as we can. Please feel free to post your questions anytime of this discussion. So I want it to be more of an open discussion. The problem is I might not be able to cover everything I want or that was posted to me. So I'll start with my disclosure. These are probably, some of this might be relevant, but I will only present the published data on constituents of migraine. However, since there is very limited evidence in pediatric migraine treatment, I will actually mention some of the off-label treatments that I use in my practice. These are the tons of questions which came from the Migraine Canada members, where I based my my presentation for this evening. So just to start with, this is our outline for our discussion this evening. So I at the end of this talk, I was hoping that you recognize the scope and burden of headache and migraine in children and your adolescent kids. Discuss the potential causes, common triggers, diagnosis, and other symptoms of migraine in our young population. Describe the role of education and implementing non-pharmacologic therapies in headache management in these young patients. And I'll also give you an update on the evidence-based strategies for acute and prevention therapies in pediatric migraine as well. So why do we need to even worry about migraine and headache in general in children, in young populations? So the World Health Organization had this global burden of disease study, which was published in 2019, and they noted that headache, specifically migraine, is the second most disabling condition worldwide among adolescents. 60% of these young patients experience significant headache, and up to 9% of them will have migraine. And migraine is the second most common chronic recurrent, meaning repeated episodes of headache in children. And there's some studies as well which showed that the quality of life of these young patients with migraine is similar to those with rheumatoid arthritis or cancer. And you can imagine why, because there's so many patients who have these headache disorders, specifically migraine, and the problem is they're usually under-recognized and under-treated. We know this, like I'm sure you've heard about this, and it's also in the Migraine Canada website that 1 billion people have migraine worldwide, and specifically 1 in 11 children will also have migraine. And in Canada, there's around 2.5 to 3.6 million Canadians who have migraine as well. What's the impact of migraine in school performance? I think this is one of the most important, more important questions that came up from the Migraine Canada members, which I like. So I would answer this specifically. Children with migraine have often missed school days. Some of them lost 2 school days in a month, not perform usual activities 2 up to 4 days. And then they also led to poor school performance because of their frequent migraine attacks, specifically for patients with chronic migraine wherein they're having 15 or more headache days in a month. This is also because of the longer duration of their migraine attacks. The reason for that is sometimes they're not given enough treatment or appropriate treatment to actually knock out or their headache attacks. They have more intense and severe attacks. Why? Because they're often associated with nausea and vomiting. And they're coming from poorer home as well. That's one of the reasons why what study actually pointed that one out. It also led to below average school performance because when they're having their migraine attacks, they have difficulty in concentrating and they have slowness in thinking, right? That's more slowness in I'm sure you had your migraine attacks as well. I do have migraine as well. When I do have my migraine attack, it's slow to process things, right? The feeling of sadness is very important in about more than 50% of patients. And some of them struggle to cope with a headache. So because they're very young, they don't know yet how to cope with pain, right? And not telling that because I do also see patients who are adults and they're having a hard time actually coping with pain, more so with young patients. And they do not want others noticing their headache. And I'm sure that's something that you actually experienced when you were younger, when you were having your headaches, because they think that it's not cool to have a headache. And it's not just from, the burden is not just on the patient, it's also from parents like you who are having children with migraine. You're often miss work, of course, because you have to stay with them, right? And about 6% prohibited by parents to engage on school activity as well. How common is it? As I mentioned, about 10 to 11% of children will have migraine. And the age of onset usually ranges in different age group. Number one, it is different in young male patients, and also it's different in female patients. So I can tell you that in males, it's younger in onset. Usually in females, it's near whenever they start their period. So the mean age of onset in boys is about 7 years, and in girls is about 11 years, which is coincident to 1 to 2 years or 1 to 2 years before or after they start having their period. So in the younger, less than 12 years of age, as you can see here, usually there are more boys during that age, and when they reach the puberty, more than 12 years of age, that's when females actually predominates. There was one who actually asked what causes migraine, and I'm sorry about this slide because it's a very heavy slide, because this is the best way I can tell you what causes migraine. I think the easiest answer to this is we don't know yet 100% what's causing migraine, but we do have a lot of studies now which came out for the past 5 to 10 years that we know there are other biomarkers that we've identified that we're trying to actually target the migraine treatment. So we know that it's actually inherited. So approximately there are 38 gene polymorphisms which were identified, but I think there's more. And then it could be environment. Of course, you know that if there is some changes in the barometric pressure or there's some stress, that would trigger a migraine attack. There are some patients who are very sensitive in terms of like MSG, for example, or they have like colored dyes, flavored dyes, or like patients with nitrites, for example, can trigger their migraine attacks. It could be a neuroendocrine abnormalities, and hormones is a big issue as well. And there's some drugs which are exacerbating migraine attacks as well. So because of these multiple factors, then there is a series of events which actually been found on a lot of imaging studies. There is this hypothalamic activation. This is exactly where that is. What's the hypothalamus? It's the part of our brain which is responsible for sleeping. Our memory as well is there, and behavior is there. So sometimes when you have, it can be sluggish or get fatigued when you have a lesion there in that part of our brain. And then it can actually cause alteration in the thalamus, which is this area of our brain, which is actually one of the parts of our brain which actually is which is responsible for pain transmission. And there are some studies as well which showed that our patient migraine brains can have abnormal brain connectivity. And then that is followed by the brainstem activation. The brainstem activation is this part of our brain, and that's the center of nausea and vomiting. And that's the reason why patients with migraine will have nausea and vomiting as part of their symptoms. And more evidence now that it could be the disorder of sensory processing, the way that we actually process pain, the way that we process changes in pressure, for example. That's actually more of one of the reasons why migraine could sense actually when there's a change in pressure outside or when there's a change in temperature outside. And the cortical spreading depression is the mechanism why how on migraine aura, like a visual aura or numbness and tingling associated with migraine, or speech problems associated with migraine. And then after that, there is going to be a release of the CGRP and all the biomarkers like PCAP. These are the neuroinflammatory peptides, which are found to be the target now for migraine. And because of this combination of migraine genes, hormonal and metabolic state, and then drugs, then this explains why a patient, even in the same family, they have different ways on how their migraine actually comes out, or they have different symptoms with their migraine attacks. Is migraine hereditary? As I mentioned, genetic is one of the most common causes, and these are different genes. I don't think you need to more of memorize them, but because there's no single gene yet that is been found to be connected, even in same family, they have different gene mutation that was found in each family. So they can't really say there's nothing yet that confirmed that this is exactly the gene mutation responsible for the migraine. 34 to 64% of them are estimated to be bilateral. Sorry about that. I usually turn off my phone, but since I'm on call tonight, I apologize that I have to turn it on. For among those patients with migraine without aura, a first-degree relative, which is 2 times likely to have a migraine without aura, and there's 1.4 times likely to have migraine with aura. And for those first-degree relative of a patient with migraine with aura, they are 4 times likely to have migraine with aura, and there's no increased risk of migraine without aura. So this is why one of the reasons why I asked the parents of my family if what kind of migraine do they have, if they have aura. If I see a patient who's very young, I potentially tell them that watch out for the other symptoms associated with the migraine of your child because they may develop some auras in the future. You always actually, some of the doctors will always tell you, especially headache neurologists, that to do a headache diary. That's very important. And we almost always tell them that we try as much as we can to identify what triggers their headaches. It's because it's one of the best strategies to avoid triggers and reduce their migraine frequency. This is a very old study done in 2012 among children. It's only 102. But they noted that stress, lack of sleep, warm climate, and video games actually, so because of the screen, the blue light from screens, which actually trigger migraine attack, that's actually one of the most common causes or triggers for migraine. And we need you to prepare before your appointment with your doctors, especially headache neurologists or other neurologists or your pediatrician, because we have, it's so hard to actually get a history from children. So we rely a lot on the parents. And we actually ask the child, even if they're younger, I ask questions. So that's the reason why I need to see the patient with you, because I ask them to draw while we're talking about the other parts of the history. I ask them to draw because studies have shown that if you ask them to draw, this is the best way that they can actually describe how they're feeling in terms of if it's a pounding headache or it's a pressure headache. And sometimes we also ask them about sensitivity to light or sound, right? And we can't expect a young child to say that I'm sensitive to light or sound. So we ask you how your child is behaving when they're having a migraine attack. Do they cover their eyes? Do they cover their ears? So that is inferred in their behavior that there's some sensitivity to light and sound, which are the things that we commonly ask, or one of the diagnostic criteria for migraine, especially in children, right? We also look for clues in their history. That's why we ask you, are there any patient or are there any family members with migraine? There are these episodic syndromes associated with migraine, which I'm going to discuss in a bit. We almost always screen for comorbidities like depression, anxiety, obesity, suicidal ideation, and adverse childhood experience, which I'm going to tackle in a few minutes. We do ask for the past health history. Why? I always tell this to my patients that if I just treat their headaches and I don't treat the other things that could potentially affect their headaches, the headaches will not get any better. Why? Because we need to treat those, and we need your family doctor's help, or whoever the other health specialists who are actually taking care of you, to actually collaborate and coordinate in terms of your treatment plans, right? So for patients with, and this study has been done in 2018, that they found that patients with migraine have psychiatric symptoms like internalizing symptoms or disorders, ADHD or attention deficit or hyperactivity disorder, Tourette syndrome, and suicidal ideation. Some of them, they have neurologic symptoms as well, like restless leg syndrome and epilepsy. and other medical issues like obesity, asthma, atopic dermatitis, anemia. Anemia is something that I always screen for because specifically iron deficiency anemia can worsen migraine attacks, and sleep disorders. We know that sleep is one of the most common triggers for migraine. How about mental health? Is that common? Yes, as I mentioned a while in the previous slide, that the children with migraine have twice the risk of having anxiety or depression, and they have 3 times the odds of having suicidal ideation. Adverse childhood experience are traumatic experiences that a child has experienced or an adult has experienced for the past 18 years of their life. It's a risk factor, was known to be a risk factor for adolescent migraine. The more adverse childhood experience that you have can worsen migraine. And adverse childhood experience doesn't have to be like physical, sexual, or any kind of abuse. It could be more of loss of a family member, or illness in the family, or bullying. That's very, very rampant right now, whether it be physical or it could be more of social media, right? So I think those are the things that we want the parents to actually know and to monitor in their children, because this could impact their mental health and also their development, and can also worsen their migraine attacks. So I thought we actually discuss a case. Of course, this is not the real name of the patient. So we'll call the patient as Charlie. So he's an 8-year-old boy who had, at 5 years old, had started having headaches. They're only happening 1 to 2 times a month. Sleeps then back to baseline after 1 to 2 hours. So that's usually the common story that you will hear from your relatives or your children with migraine. And then at 6 years old, she developed this tummy pain around the belly button, and they were more of dull. And you notice that Charlie was turning pale. They may complain of some nausea, and they're happening every 2 months for 6 to 8 hours. There are no headaches, and they're normal in between the attacks. You brought the patient to their pediatrician. They look at everything, and nothing came out. And about in 2022, the Charlie's headaches increased to once a week. Now they're lasting longer, to up to 6 hours. They're more intense. That's why he was missing school 1 to 2 times a month. He also is still nauseous with the headaches and prefers to rest in a dark and quiet room. You check for red flags like more of fever, all of those things that are worrisome symptoms, and he did not present with any. And the triggers included weather changes and dehydration. She was colicky as a baby, and she also has motion sickness. I will tell you why those are important. And the family history showed that his mom and maternal grandmother have migraine. And we examined the patient and did not see any abnormal findings. So everything was normal. So this patient I diagnosed him with migraine without aura because they're only having 1 to 2 times in a month. The tummy pain that he had was in keeping with abdominal migraine, which is an early manifestation of migraine in a young child when he was 6, right? And remember, he was also colicky, and that's what you call infant colic, which was also found to be related or associated to migraine. In the new guidelines, probably it will come out next year, that will be included as one of the episodic syndromes associated with migraine. So what are these early signs of migraine in younger children? As I mentioned, we have abdominal migraine. Then we have this benign paroxysmal torticollis. It's more of the tilting of the head. It happens in between 3 to 6 months, and they go away in time. So they will tilt their head for maybe a few hours and then back to themselves as if nothing had happened. And then in a week or 2 weeks or a month, then they tilt the head again, either right or left. The one thing that's important here is that you need to bring your child, because we need to check for other things, that worrisome things, like something happening at the back of the head of the child. So majority of the time, if they have normal neurologic examination, we just monitor them. But if they continue or they become much longer, then we do neuroimaging, right? And then the next one is the cyclic vomiting syndrome. So this is one of the few wherein they can actually start around 9 to 10 years of age, and they can persist even at 19 years old or 20 years of age. I do have young patients with cyclic vomiting syndrome as well. So they would have no headache, but sometimes they would have vomiting and repeated episodes of vomiting, sometimes for hours or sometimes days. And they will have, it happens every 4 to 5 weeks or every 5 months or something like that. Some are infrequent, some can be very disabling. That's why they needed to see me or another headache neurologist that's why we need to start some medication to prevent the further attacks. And then there's another thing called benign paroxysmal vertigo, wherein they have repeated episodes of spinning sensation, not themselves, but more of themselves spinning, right? And it could last hours as well. It could last days. Again, they actually happen every 3 months in some patients. It happens every 10 weeks in some patients, but in between the attacks, they could be normal. So again, there are all these syndromes, they actually are associated with migraine, and they could be periodic, meaning and normal. The patient is normal between attacks. They could have either pallor or pale. They become pale. They can have some flushing of their face as well. There's always a strong family history of migraine in their first degree relative, and majority of them clinically evolve, meaning they actually turn into migraine at a later age. There are other things like infant colic, as I mentioned, alternating hemiplegia of childhood, and vestibular migraine. There are some other disorders which are under investigation, like the motion sickness called stimulus headache. Recurrent limb pain is sometimes they call it growing pains. And there's some periodic sleep disorders like sleepwalking, sleep talking, night terrors, or bruxism, which is grinding of the teeth during sleep. These are not yet included, but they're being investigated that they can potentially be associated with migraine. What's the connection of the gut symptoms to migraine? As I mentioned, in younger children, they have more of the nausea and the vomiting symptoms. And then when they turn into teens, then those who actually improve, then they will have the sensitivity to light and sound. So there are some theories why the gut is almost always considered in my review as more of a part of the brain, because majority of the chemicals that are associated with migraine, like the neurokinin, vasointestinal peptide, and substance P, are also found in our gut. And there's some theories why it could be potentially associated with migraine. So the hypothalamus, remember that part of our brain which is responsible for sleep, behavior, memory, and all those things? So that is a connection on that, on our pituitary gland and the adrenals. So there might be some problems with that in these patients. There are some also problem with this patient that is inherited susceptibility, so the genetics again. And then the autonomic instability. Autonomic means that this is the one responsible for the heart rate, blood pressure as well, and that has some instability in terms of that. And then there's some altered motility of the gut wall is the other one, and there could be some visceral hypersensitivity and dysmotility. You might wonder, the other question that came up is in patients with headache, in younger patients with headache, when do we worry and when do we scan? So we always make sure that we take a good history. That's the most important one. And this has been shown in different studies that if any scans or neuroimaging is not indicated if a patient comes to us with a recurrent headache with a normal neurologic examination. So all the doctors who are seeing your children with headache or migraine, they needed to have a complete neurologic examination, because that's help us to decide if we need to do CT scans or MRIs. And we only consider them based on a lot of studies if they do have abnormal neurologic examination. Papilledema means they're swelling at the back of the eyes, where in the nerves, the optic nerves has some swelling, decreased level of consciousness, weakness, or unsteady gait. they have been shown to have these patients presenting with this have significant findings on their MRI or CT scans. There is some also predictors of presence of a lesion in the brain if the headaches are initially presenting less than 1 month, absence of a family history of migraine, abnormal neurologic examination, gait abnormalities, and also seizures. The parts of the other history have been inconsistent findings for the past year, so we don't actually rely on them too much. We rely more on our neurologic examination before we do any neuroimaging, whether it be a CT scan or MRI. So now the other thing is that in children, when do we know if a headache is a migraine? It's basically the same as in adults. The only difference is that it's shorter. In children, it's shorter. It's only 2 to 72 hours. The child should have at least 5 attacks. And in children, in older patients, it's usually one side, right, of the head that hurts, but 80% in children, and specifically in adolescents, can be bilateral. It's also more commonly found. The pain is mostly on the frontal area. The pounding quality of the headache, of course, in younger patient, you won't actually get that pounding history, right? So, and that has been shown in studies that 40 to 60% of them can be pounding. But usually a child with migraine will stop whatever they're doing. They stop playing, they stop watching TV whenever they have a headache, and they're moderate to severe intensity. And as I mentioned, majority of them will have nausea or vomiting. But if a patient does not have nausea or vomiting, the patient should have should be sensitive to both light and sound. Okay. And there are different phases of migraine attack, and these are also seen in younger patients. So please don't think that they won't present with craving for food, for example, or yawning, or heightened perception for like weather, for example. They could present with auras as well, and then their headaches are basically the same. And then they could have some hangover symptoms as well after their headache attack. One important thing that I usually tell all my, when I do a lecture for everyone, whether it be from family doctor, from pediatrician, and also for patients, is that the role of doctors to actually, and you as parents of young patients with migraine, is very important, because you need to be aware of this, number one. And number two, they needed to actually have a diagnosis early, because early diagnosis will mean that there will be some appropriate treatment started on your children. And the other thing, that actually improves the prognosis of your children with migraine, because that has been shown in studies consistently that if you start early in terms of the treatment, then they don't go to the chronic migraine stage. And there's different goals for pediatric treatment. Number one goal is to reduce the disability. So we don't want them missing school. And we also need to teach them how to develop like pain coping strategies, right? And that will also help reduce the risk of disease progression from episodic to chronic migraine. And because of that, they will actually have better quality of life. And we can achieve this in few different things, 4 strategies. So self-management that's where you actually has a big role in this. And then, as I mentioned, treat all the other things that are commonly found. Like if you have patients with sleep problems, we have to treat that one. We have to make that better. If your child has some mental health issue, we need to treat that. If we need to actually get you to go do a cognitive behavior therapy, then that's I think that's our first line of treatment for them. And then the medications are divided into 2, the acute or rescue therapy or the prevention therapy. Here is the table that we actually all share to our patients at Women's College Hospital. We started this when I was at Women's College Hospital and at Sick Kids. I'm still at Sick Kids, by the way, but I'm not connected with, I'm not doing my practice at Women's College Hospital. I'm partly connected doing some research there. There's the supplements. We almost always start this mainly because even if they have low evidence for children, mainly because they have low side effect profile. And there are some children who definitely actually benefit from this. Screen time is something that we actually try to see if we can stop them or avoid them. if they can't stop, if they're using it for learning, then I usually don't stop them from using it. I ask them to take frequent breaks. So 1 hour of screen and 5 to 10 minute break, and then go back to it again. Hydration is very important. Headache diary, Canadian Migraine Tracker, which is supported by Migraine Canada as well. And then having physical activity, which is not a big problem for children because they're definitely very active, avoiding what triggers them. So having the diary is actually going to help identify what triggers their migraine attacks. Sleep. Sleep is something that I spend a lot of time actually discussing with my patients. It's not just a number of hours of sleep. It's the regular sleeping and waking time that matters a lot as well. I think that's something that you need to actually explain or make sure that your children will have those regular sleeping time and waking time. I love oversleeping, but if I oversleep for more than an hour, I'll have a big headache on a Sunday afternoon or Monday morning. So oversleep for an hour, not more than that, because that can potentially trigger a migraine attack. Eating, please do not skip any meal. High protein for breakfast is something that's actually we advise because low blood sugar can trigger migraine. And the downtime. Among all the treatments for migraine, cognitive behavior therapy has been found to be useful. And I can tell you that that when you actually have children with this, focus on the function during the migraine attack, not on the pain. Okay, so I think mainly because majority of the medications sometimes would not help, especially if you actually gave the medicine too late, right? Okay, so there's a question about the role of the psychological interventions like cognitive behavior therapy. And this is just to show you that there are 9 trials in children with migraine comparing non-medication intervention to control or another non-pharmacologic therapies. And it showed that short and long-term outcomes are better with non-medication therapies. And that's the reason why we spend so much time on discussing this, and we provide a lot of apps for parents. It's important to treat early. I'm sure you've heard this from your neurologists or from the doctors who actually told you to start early in terms of treatment. I show this picture to my young patient, even if they're 5 or 6. Why? Because it's up to them for them to tell you, the parent, to actually that their migraine is starting or the headache is starting. Because if you treat it late, then there is this pain switch in the brain that turns on. So, and studies have shown that if you treat early, then there's more success that you will be the treatment. If you treat late, the problem is in terms of success from that treatment, it drops from 80% to 50%. There is a lower recurrence rate as well if you treat early, meaning it doesn't come back, right? And there will be lower adverse event rate, meaning there will be less nausea, less vomiting, because as I mentioned, this part of our brain is the center for nausea and vomiting. I don't know if you're familiar with this. It's called Traley map. This is the traffic light of migraine that I actually discuss with our patients. So it doesn't include only headache, but also all the other symptoms of migraine, whether it be nausea, vomiting, sensitivity to light, or sign or fogginess, right? So a red migraine means they have to stop. It's based on how they're functioning. Yellow migraine, they have to slow down, and green migraine, they can go. And depending on that, there are some triptans which are unfortunately not approved here in Canada, but the only one approved in Canada is the amitriptyline. But for the US guidelines to be used, and I use it for more than 6, that we can use the rizatriptan disintegrating tablet. And for 12 years old, I can use amitriptyline, rizatriptan, the combination sumatriptan, naproxen, or Suvex, the sumatriptan nasal spray, and zolmitriptan nasal spray. And anti-inflammatory medications like ibuprofen and naproxen can be used. And if they have nausea, then I give nausea medication as well. And when they start prevention therapy, if they have frequent headache and they have migraine disability and or both, like, so meaning it's mainly based on the disability, or if they're overusing medications. And there's like 3 medications which were approved with level B recommendation. 1 is propranolol, 2 is topiramate, and the other 3rd one is amitriptyline. How about the vitamin supplements? As I've mentioned, there is no great evidence that they work, but on majority of the trials that were done, is the coenzyme Q10 and magnesium has been useful with low side effect profile. That's the reason why majority of my patients are on magnesium and coenzyme Q10. How about the new migraine therapies? Can we use them in children? Yes, because we have evidence that the CGRP levels are not just elevated in adults, but also in pediatric migraine patients. What are this? Ubrogepant, rimegepant apparently was just approved last Friday for acute therapy in adults. And zavegepant is potentially coming. This is a nasal spray, and atogepant can be used as prevention. All of this, including the erenumab, galcanezumab, fremanezumab, and octinizumab, all of the trials in pediatric migraine trials are being done, not just here in Canada, but also in the US. Zavegepant, I will start the trial in Children's Hospital, hopefully early next year. The atogepant, that we will start that soon as well at the Children's Hospital. The erenumab trial for pediatric patients is ongoing at Sick Kids, which I'm the principal investigator, and also at Children's Hospital. And the iptinuzumab trial is actually going to start soon at the Children's Hospital. Okay, so all of this, and we are making sure that these drugs will be tested in younger patients so they can be available. And you don't have to pay it out of pocket, because once they approve, then your insurance will cover them. How about the devices? Unfortunately, we don't have all of this. We only have the non-invasive vagal stimulator, which is the GammaCore, and also the Cephaly, which is the electrical trigeminal nerve stimulation. So there's not much evidence on the use of Cephaly, but there is some evidence because this is the cheapest that we have here in Canada. This is the most common ones that I use as an off-label treatment. The GammaCore, it's approved for 12 years old and up, but the problem, and there's some evidence for their use in adolescent patients, like 12 years old and up. The problem is they're so expensive. For Cephaly, it costs around $500, and for GammaCore, for 3-month treatment, it's actually around $1,600 to $1,800. Right? So they're quite expensive, and majority of your insurance coverage will actually not cover them, except for some, like maybe Sun Life will cover Cephaly, but there's some few patients who actually will cover those devices. And what's your role as parents for your child? I think all the things that I mentioned about the self-management strategies, like the diet, the hydration, sleep, exercise, stress management, school, advocating for school, is actually very important, right? So, and making sure that they're physically active, the home life, make it as normal as possible, and then identifying the triggers and taking the medication early, and life balance, and actually pacing. These are very important in terms of your role as a parent and guiding your children with migraine. Again, focus on function, not on pain. As I mentioned, your role as in this is in the self-management, helping them develop pain scoping skills, and using the headache diary, and then monitoring the symptoms and advocating for your child in school and healthcare providers as well. And treat early. Once they have the treatment available and prescribed by your doctor, please treat early, and then teach them when to tell you. And if you do have, there are attacks which are happening in school, then get a letter from your doctor. And that letter is actually available in Migraine Canada, because the PCAN group that I'm co-leading with Dr. Orr is actually one of the things that we did. So all you have to do is get that letter and ask your family doctor to actually sign it, so you can actually give that to school, so the teacher or the principal can give the medicine to the in school, once the headache starts. And then prevention therapy, and to improve compliance, right? So you can help make sure that, because that prevention therapy is not going to be forever, right? Once they are better, then we can actually get rid of it at some point. So what happens in patients with pediatric migraine if the studies have shown that if the headache starts early, if the migraine starts early, then there is a highly likelihood that it could develop into chronic migraine. But it can also get better as well. And in male patients, I tell them they're very lucky because they don't have the hormonal effects or side effects on migraine. Then on their late teens or early 20s, majority of their migraine attacks are much, much lesser. They can happen once or twice in a year. We can't get rid of all of them, but they're less often. And in patients with early developmental disorders, unfortunately, they may be associated with persistence of migraine. So the heart of migraine management in children of adolescents is usually education, shared decision-making, and we actually make sure that we individualize the treatment. And there are 4 key aspects, as I kept on telling you that. So acute treatment, which are the rescue medicines, the prevention therapy. If your child has frequent headaches with frequent disability or overusing medications, then they need to be on prevention therapy for a while. Usually we maintain it for 6 to 12 months because studies have shown that even if you take away the medicines after 6 months, for example, then the headaches will not worsen. Self-management and education is going to be your part. You have a big role in that. Please help us with that. And of course, the comorbidity management. The bottom line is we know we are now in the era that we exactly understand what's happening during a migraine attack in the brain. So based on this understanding, we're designing treatment options or we're making them individualized treatment. The trials in the pediatric patients are still ongoing, but we're hoping someday we'll actually going to be successful in finding out and making those available for your children. Thank you for your attention.